Good evening, everybody, and welcome to this is June. It sort of feels like July, but June conversation with a doc. We are really thrilled and lucky and happy that Dr. Paul Fishman is here this evening to talk about focused ultrasound and Parkinson's disease. And I'm not going to say another word. I want him to have all the time that we can have. Um, for those of you who have asked, this is being recorded. All the conversations with the doc are recorded, and this one will be up on the MAPS website by Friday at the latest. And with that, Paul, I'm going to turn it over to you.
Well, thank you. And thanks, Judy, for the invitation. My thanks to Mark for setting everything up here. Hopefully, it will go seamlessly. And thanks for all you folks out in the virtual world in your homes who are taking time off to join this today. So that's me. And that's not me, although that's one of my idols. That's Irving Cooper, who basically invented surgery for Parkinson's disease. He did 5,000 cases in his lifetime, and he did it with homemade equipment. Let's see. Uh, that thing in the middle, I don't know if you can see my cursor. Can anybody see the cursor? Okay. Yeah. Yeah. Uh, that's homemade. He had a machine shop in St. Barnabas Hospital where he worked. This is all before commercial stereotactic frames. And this is even before CT. It's not only before MRI. Imaging at that point used what was called a pneumoencephalogram.
Ah,
It was no fun for patients. It injected air into by a spinal tap. And what you're seeing over there is an air fluid level. That's how the landmarks were. They knew that those were the fluid spaces of the brain because they could see the air fluid level. Uh, I had never had one done to me. I've been told it gives you one hell of a headache, and that's one of the many reasons it's no longer done. Uh, and it was kind of good news and bad news. It really, for some of the symptoms of Parkinson's, particularly tremor, it was remarkable. Patients with severe tremors, some of them were totally taken away. But particularly when they went to do both sides, uh, you know, pretty much like we all learned in high school, that the right side of your body is controlled by the left side of your brain, and the left hand is controlled by the right side of your brain. And nobody wants to ask, what about all the things in the middle of the body? Well, they're coordinated by both sides of the brain. And when you're trying to make lesions for both hands, sometimes you wind up with severe problems in the middle of the body. And that's speech, swallowing, and balance. Those require coordination of both sides. And uh, for a time, the side effects were so severe that this type of surgery was abandoned. Well, it made a comeback in the 1990s. Now you had MRI. You also had commercially made, very refined with, let's just say the type of machine tools that are used to make centrifuges to make nuclear weapons are the type of machine tools that are used to make these stereotactic frames. They have accuracy 16th of an inch within the brain. So you can do targets, very small targets within the brain. The other part is because of the problems of this coordination of both sides of brain and speech and swallowing and how variable it was between people, that was the whole rationale to invent deep brain stimulation. Because deep brain stimulation doesn't destroy brain, it basically puts in a jamming signal and temporarily alters brain. And then if you get into problems, it's adjustable. It's just like if the volume on your stereo is too high, you can turn it, the radio, you can turn it down. And if there's too much stimulation with these implantable systems, you can easily turn it down. So there's no intentional brain destruction. And the key word in that sentence is intentional. There's always the likelihood of unintentional brain damage. And every surgical consent form for every procedure has these two words in them. The two words that always appear are bleeding or infection. And you don't have to be a neurologist to agree with me that the worst place you would want to have bleeding or infection is in your brain. So that is something that's still with us, 25 years after the FDA approval of DBS. And that was the incentive to develop another technique. And it only was, 70 years in the making of using focused sound energy to make a brain lesion. And for my colleagues who know much more engineering than I do, uh, I'm from an engineering family. And as a physician, I had my brother-in-law tell me to my face, "What's the definition of a physician?" I said, "Tom, tell me." He said, "The definition of a physician is a professional without the mathematical skills to be an engineer." And so the answer is, I really don't understand this, but I know that it works. And part of it, uh, so I love this picture because it looks like Dr. Frankenstein. That's one of the Frey brothers who pioneered this work. And that thing has four emitters, and he's using it to fry part of a monkey or cat brain.
Mm.
Uh, he was able to do it only after the skull was removed. So the current devices wouldn't be particularly non-invasive if you had to remove the skull to do this procedure. Uh, you have to shave the head, but there's no cutting, there's no drilling. And as I said, the engineering to it is amazing because sound bounces all over the place, it's absorbed. So steering sound is the engineering feat that literally took 20 years to lick. And to focus it, so much of the sound gets bounced or absorbed by the skull, it takes 1,000 separate emitters, beams, to actually uh, hit the target. Because when the sound energy hits the target, it's converted to heat. And heat, for those of you who are into cooking, is usually controllable. That's what you want to do. If you want to destroy something or do something gradually, heat is a great way of doing it. Because when you heat brain up, and this is the centigrade scale, so 37 is 98.6. That's a normal body temperature. Well, if you gradually heat brain up to 10 degrees of that, 47, you don't kill brain, but you certainly will interrupt brain function. And that's a way of monitoring this technique. Because say it's tremor. What you ought to see with a sound burst, and the machines are so good, they can calculate uh, how much the temperature rise will be in brain by the amount of energy they put in. So you dial in, you want to go up to 47, you get to 47. And if you're standing with that patient and you're right in the right spot at 47, the tremor starts to calm down. Great.
Mm.
That's going it. Everything's going well. You kick up the power. And once you get it to 47, to 57, that's lethal brain temperature. If you cook brain for even 15 seconds at 57, it's dead. It's cooked. But you don't do that until you know you're on target. Because say if you go down to that injurious but not deadly level, and say a person says, my grip is not so good, my speech got a little slurred, then you don't hit it with a higher power. You adjust the target and just invisible to the patient in the control room, you can just move it left or right. There's no physical probe. So the target just gets shifted and you can actually see a map of brain temperature, and that's what's in the top one. You don't like where the temperature is going, turn the dials, on the control room, move it left, move it right, move it up, move it down until it's right on target. And again, you don't make a permanent lesion until both of those things look good. Well, in terms of targets, and one of the many, so if people criticize me as a physician, sometimes I'm a little bit too flippant. Some people appreciate that, other people would expect a little more serious. Well, one of the flippant things I commonly say to patients who are thinking about these types of surgeries for Parkinson's, that in general, having part of your brain coagulated is a terrible idea. Uh, and only in very specific situation, uh, I think the old neurosurgical adage is sometimes bad brain is worse than no brain. So there are brain active areas that are overactive, and maybe the patient actually is better off having those areas taken out or destroyed. And when you think about destructive uh, surgery that actually helps people, it really boils down mostly to two fields. And I learned a lot from my wife, who's retired now, but she was an epilepsy specialist. And epilepsy, people with seizures that wouldn't go away with medication, was one of the first situations where if you destroyed or took out brain, the patient was actually better off. So temporal lobectomies, uh, now, for psychiatric reasons, has a very wishy-washy. Sometimes people are benefited, sometimes people are harmed. But in epilepsy, epilepsy surgery has been around longer than movement disorder surgery, which now moved into that field. In the field of movement disorders, where there are abnormal movements or abnormal brain activity, the patient is sometimes better if that area is destroyed. And again, we're talking about small areas, areas about the size of a BB. And both from the old days to DBS and to now, there have been three standard areas that are the targets, usually for three different patient profiles. One area, the oldest area, is in the thalamus. That can wipe out tremor. And it doesn't even matter sometimes the type of tremor. The same target is for people who have essential tremor without Parkinson's or a terrible Parkinson's related tremor. This area doesn't do much else, but it's terrific for taking away tremor. And then the commonest target that's used for DBS is the subthalamic nucleus or STN. I would say that 50% or more of Parkinson's patients who have DBS surgery, the STN's the target. And the target is what are called dose fluctuations, particularly patients, the medications don't work or they work erratically. And the goal is to be as functional as you are at your best with medication, but have that be your entire waking day. So having your off be as good as your on. The third target, the GPI, works pretty well for dose fluctuations, but it's wonderful for knocking out the levodopa-induced movements, the dyskinesias, the Michael J. Fox stuff that you see in people who have been on levodopa for many years. So again, three targets for three different patient profiles. Occasionally, a patient will have DBS with one target on one side and another target on the other side. You know, somebody has a terrible tremor on one side, but they have a lot of stiffness and slowness and bad off on the other, they might get it. Matter of fact, we did a case Friday where very skilled neurosurgeon hit two targets with one electrode. One of the companies makes a really long electrode. You can actually put it into two targets. It does take a skilled neurosurgeon. And of course, the disclaimer is I'm a neurologist, not a neurosurgeon. I assist neurosurgeon. Uh, the closest I come to neurosurgery is pressing a button that moves the probe up and down. So I don't do any of the cutting. So here's some of the data. So this is focused ultrasound with patients who have severe tremor
Wow.
Uh, uh, and it was not my idea. It was the FDA's idea that these studies had to be done with sham surgery. So there's a group that got their head shaved, where the people involved, sometimes me, would go into the room with the patient and pretend that they were being treated. I don't know how well this worked. I'm not a very good actor. Most of the time, the people could figure it out, but that was the FDA. It had to be a sham controlled study. And then afterwards, at the 3 month mark, even the sham people got treated. So some of the people, as you can see, even got better with sham surgery, but the amount of improvement, usually on the order of it, 60% is kind of average reduction. If the hand is moving like that, it calms down to about that. So about 60, maybe 70% reduction. Common side effects, mild, short term, are common. Remember, we're heating things up. And again, the cooking analogy, heat spreads. And sometimes the heat will spread and can injure neighboring brain areas. It doesn't happen. Commonly, it happens mildly about 10% of times. It's severe 1% of times usually. And it's either numbness and sometimes it's imbalance. So that was FDA approved in 2018. What about other conditions for Parkinson's? And the first one we did was we went to that old-fashioned pallidotomy surgery, particularly for people uh, with dyskinesias. So they had both wearing off, where their medications weren't working and their tremor would come back and their loss of dexterity, but then they also had dyskinesias. And we actually did the first study in the United States of that. And you can see how this thing is incredibly, it's not the fault of the machine. If somebody doesn't have a terrific outcome, it's the design of things, because the machine will put the lesion where you want it. And let's see, in that black arrow, so that whole thing with haze, that's damaged area and injured area. And then after 6 months, things shrink down. And again, that's about the size of a BB. So where that black arrow is in my cursor, it's exactly where we put it. I can't remember a surprise where we thought that the lesion was going to be here, but the lesion appeared someplace else. But the issue is sometimes it can touch brain tissue. So with a small study that looked promising without significant side effects, then you get the go-ahead from the FDA to do a larger study. And a larger study, and also just see that it's not just us, that any medical center doing it the same way could give similar results. So it was 16 centers around the world, 94 people were involved, volunteers, and they were more typical DBS patients. Some of them had dyskinesias, some of them didn't. Some had a lot of wearing off, but they had to have at least one of those. And even though we were doing one side, as long as they had one bad side, they didn't have to have all their Parkinson on one side. And it was helpful. The vast majority of people would judge themselves to be a responder, that they at least had some moderate improvement. So, whereas very few people in the placebo group would say, yeah, I really got better. And then if that's at the 3 month mark, through the 12 months of the study, they pretty much kept that response. The average amount of improvement during off was less than you see in DBS, because remember, it's not adjustable. If DBS in your off gives you 50% improvement, this gave you about 30% improvement, maybe a little more. But again, what was really remarkable, remember, it's close to unheard of to see bleeding or infection with this, because there's no opening of the skull and there's no physical probe poking through the brain. There are these situations where the heat spreads. So basically, the Side effects were almost all mild. There were a few that would be viewed as moderate, moderate weakness of grip at a week, some degree of imbalance. But none of these 60-something patients who were treated, none of them had a severe side effect that was related to the procedure. One person, probably because of the extent of time that they were lying on the table, did get a blood clot in their veins, which then resulted in a pulmonary embolus. But that was probably because they were just lying on the table for hours. Uh, Only a few groups in the world try to attack the commonest site that's attacked for
Hmm.
DBS, and that's the subthalamic nucleus. And that's because it's small, and if you damage it too extensively, you can unleash involuntary movements. So if you imagine a Parkinson's patient who has slow, laborious movements, uh, that this area is overactive. You can tone it down with DBS, but if you actually destroy it, you can actually unleash wild movements. And we've known this for decades because if somebody has a small stroke in this area, if an otherwise normal person has a small stroke in this area, they get uncontrollable wild movements on that side of their body. So, and in the DBS era, nobody's wanted to lesion this. But one group, particularly in Spain, has wonderful accuracy with small lesions, and they got really good results. They got about 50% improvement, which is comparable to DBS. And were very careful with their patients because if they had patients who had dyskinesias, significant dyskinesias, they didn't do them. Because this thing, if you unleashed that, the dyskinesias get much, much worse. And they did one of the first studies where the second side of the body was treated. Now, the Spain FDA must be even worse than our FDA because these people were treated 3 years later on the second side. And if you look at that lower slide, the first 6 months they got better. And then the next line to their baseline, that's their Parkinson's getting worse because 3 years have gone by. Now they get their second side treated and it works. And again, nothing unexpected. Again, they sometimes would get increased dyskinesias, but none of the wild things about it. Uh, there have only been a handful of patients in the United States who have had this. Matter of fact, there except the one group in Japan and this group in Spain, just because the accuracy it takes to do this. So I don't know if this is ever going to catch on. But again, it just takes a skill level to do this that most centers aren't going to even try. And the alternative, and a Swiss group kind of said, well, why don't we try some places, spots in the brain that DBS has never been tried at or there's very limited experience. Maybe we can find a spot that they can lesion that can give a DBS-like effect with fewer side effects. And they said, well, sometimes we do the GPI and sometimes we do the STN. Well, what about an area that's kind of in the middle that has fibers going from both of those? Maybe we'll get a good effect on dyskinesias and we'll get a good effect on off without bad side effects. And I must admit, when I first saw this study, I really thought it was too good to be true. Uh, and again, here's their lesion, this little target kind of in between, and they got a really good result. And even with no bad side effects, with 15 patients who got it on both sides. And again, comparable to that DBS-like effect, 50% improvement. And I was not enthusiastic about this, but the FDA was. And it was one of the few situations, it's like the old joke for many things. If the FDA asks you to jump, you say, how high? So if they wanted to do it, and again, it's like, I thought it was too good to be true, but what the hell? If it really was that good, we got to go for it. And we organized a large study. Again, many groups, and Dalby's down in Texas, he kind of had the largest number of patients, and 54 of the patients had it on one side, and after a delay, in this case of 12 months, 40 of the patients had it on the other side. These are typical DBS patients, and we're up there, in the amount of improvement. If you look at the dark blue, that's where they started. And you look at the light blue, that's the first side. And, you're getting there 30, 40%. And then for some of the patients who wanted, this was patient choice. Do I think my other side is bad enough that I want that one done? And with a gap, and the gap was for the FDA to review all the safety data before they gave us the go ahead. And so what we don't know is how bad they were to start, but clearly after the second side was done, there was added benefit. And again, that same situation, lots of mild short-term side effects, 10%-ish in total, but hardly any serious side effects. And again, we did extensive studies of all of these folks. And that's what allowed, on the basis of the study, that the FDA just last year gave approval for this procedure. The both first time that treatment with focused ultrasound of both brain sides has been FDA approved. So now we're at a point we can really talk about, we have patients have these two options. How are they different? How are they similar? Well, standard of care, numbers. The numbers are on number of patients, number of places to do it. DBS has been around. I always get when I hear on the media shows a DBS case like it's new news. DBS has been FDA approved for over a quarter century. It is not a new procedure. And again, over 500,000 patients, most of them with Parkinson's worldwide, have been done. Most of the time, you still have some kind of frame, maybe not a big frame, but a little pedestal on the head. For many situations, you still need patient cooperation. More and more places are doing DBS asleep. So for many conditions, for patients, the whole idea being awake during a brain surgery, that's a non-starter. So many DBSs can be done asleep. As I mentioned, no intentional brain injury, but there is that risk of bleeding or infection, and it's a bigger deal. Most patients, it's an inpatient procedure. You're in the hospital for at least a night, usually 2 nights, and then you come back for the pacemaker placed in. So again, a 2-stage surgical procedure, but it's adjustable. So if symptoms of Parkinson's get worse over months and years, with a good implantation, you can reestablish reduction by just changing the settings of the device. And not only does it treat both sides, but you can do the procedure both sides at the exact in one sitting. This side is out of date. We're up to about 15,000 ETs and about a couple thousand Parkinson's patients. I updated the other side and not this one. Still uses a head frame. You can't do focused ultrasound asleep. You need the patient cooperation because there's no recording going on of brain activity. That's our only guide. Are you in the same place? So you can't do this asleep. You got to be in the MRI, in and out of the MRI. For now, we're getting closer to 3 hours rather than 4. But there's no cutting, there's no drilling, and again, little to no risk of bleeding or infection. And for patients who don't want an implanted device, it's a one-shot deal. You go in, you have it, it's done. And for better or worse, after it's done, you're in the cross your fingers stage in terms of will it be permanent? Will it be long-lasting? And again, this should have been updated. For tremor, you can't, and now with the recent study, you can have it on both sides, but they have to be staged at least 6 months to allow people to recover from whatever brain damage might occur. Uh, One of the things that's kind of in place is one, we really don't like to do DBS on people who are cognitively impaired. And the reason we don't is sadly in Parkinson's, dementia is common, worsening of cognition is common. And the literature says, particularly for the STN, that may make it worse. And because when you try to, the D in DBS is for deep brain stimulation. And to get to deep brain areas, you have to go through your cerebral cortex and the fibers underneath that. And that probably is not a good thing for people who have compromised thinking and memory, because they probably need all of those nerve fibers that they've got. But, and there's an intentional lesion with focused ultrasound, but it's all at the target. The rest of the brain never heats up at all. You remember, the rest of the brain sees about 1/1000th of the heat energy as the target. And so right now, there's not a lot of literature, but it really appears that focused ultrasound may be more friendly to the thinking parts of the brain because it never goes through there. And that may be a real future of this because there are plenty of people with some degree of cognitive impairment who also have motor aspects of Parkinson's that would want to be treated. Where right now, most centers are very uncomfortable with somebody with mild cognitive impairment or mild dementia. Usually that's a non-starter. And maybe those people might be better served with focused ultrasound. And now we'll move from the current to the future. Uh, so we got all these high-tech things you hear about. You hear about stem cells, and now you hear about stem cells. They can take your skin cells and make them into brain cells. You can make them into dopamine-producing brain cells in a dish, and then put them back and use them as replacement cells. Remember, this got approval in Japan this year. Okay, really high tech. How do you get those cells in? Oh, low tech. You drill a hole in somebody's skull and you take a needle in and you squirt it into the brain. Uh, and for some of those stem cell things, since the cells don't go much of the way, oh, you have to do that 4 times in each side of the brain to spread the cells around. So high tech procedure, low tech delivery system. Maybe there would be a better delivery system. But for all these big things, all the monoclonal antibodies that they do in Alzheimer's disease, remember, half the ads you see on TV are for a monoclonal antibody. Great techniques generating them, but they don't get into the brain hardly at all because they're too big. There's this thing called the blood-brain barrier. The brain is very picky about its environment. Uh, so if they take your blood and they spin it down, uh, they take the blood cells out, and you look at the serum. The serum uh, looks like honey. It's thick and it's colored. If you ever see the results of a good spinal tap, it looks like spring water. It's totally clear, totally colorless. And that's because the blood-brain barrier, the brain is in this bath of pristine spring water. None of all that stuff that's in serum gets in unless the brain specialized systems let them in. And there's all sorts of techniques that have been developed to try to get things into brain. Nanoparticles, vesicles, things that stick and transport. And one of those techniques is using focused ultrasound. Don't use it with a really high setting that'll coagulate and kill brain, but use it as a moderate setting where you pulse it. And if you pulse it, and at the time you actually put in the same kind of bubbles that you use if you've ever had an echocardiogram, they use little tiny gas bubbles to give you a better picture. Well, little tiny gas bubbles, when the sound energy hits them, they expand, contract, go nuts, bounce all over the place. And when they're bouncing all over the place and expanding, they pop open the blood-brain barrier. And scientists have been working on this for years, and they figured out how to do this without damaging the blood-brain barrier, where you get you open it up and it stays open for a few hours, and then it closes up without any brain damage. And now when it does that, you've got a couple hours to inject something into a person's vein, not their brain, and that stuff will end up in brain. And that is another use for focused ultrasound that's already, tons of animal studies already in clinical trials. So this is an animal study, and sometimes you want to get things out as well as bring them in. So these are mice where they that basically have depositions in their brain that look just like the deposits seen in Alzheimer's disease. And in this situation, they've opened up the blood-brain barrier, but the goal is to clear this abnormal protein out of the brain, and it works. The lower one has all these little black dots in the thinking part of the brain, and there are far fewer of them when the whole brain is treated with focused ultrasound, not just a little tiny target. Uh, there have been some trials already in humans where you open up the blood-brain barrier with the goal of getting amyloid out, that toxic protein out of brain. And again, already in clinical trials in Alzheimer's disease, and it's a small study and it works. So this are patients who got the first FDA-approved anti-amyloid antibody for Alzheimer's disease, designed to clear, and it does, clears amyloid, the abnormal protein, out of the brain. Does exactly what it's supposed to do. Typical treatment, those studies took a year and a half of treatment to do this. Now, this is from my colleagues at West Virginia. This stuff was on 60 Minutes. That's how much buzz it developed. And God bless him, he got this published in the New England Journal, I think, with 6 patients. I never heard of such a thing, but so that's what a blockbuster this is. Well, the upper line is the amount of amyloid, and here they're at 6 months, so 26 weeks. Hasn't done diddly. But if you combine that with focused ultrasound, which we guess gets about 10 times as much antibody into brain, boom, there's almost all of it is gone. And this even passes the sight test, particularly the arrow over here. So they didn't treat the whole brain because for safety reasons. They just treated this one patient. Here's one of the areas they treated. If red is a lot of amyloid and blue is normal, the area that was treated and only the area treated virtually became normal. And this is being continued. The question is, what's the safety of this? How do you do this without causing problems like brain swelling? That's why it's in progress. These kinds of things have application to Parkinson's as well. Sadly, one of the things a lot of my patients said, I don't, the movement stuff doesn't bother me. The idea that it's going to affect my memory and concentration, and I'm going to become demented like an Alzheimer's patient, that's the thing that scares me more than anything. And sadly, for people who have had more than a decade of Parkinson's, more than expected for age, loss of cognitive function is a real risk. After a decade, we're talking about many to most of Parkinson's patients. And we hear about the protein in Parkinson's alpha-synuclein. Great, alpha-synuclein is important. But when patients in Parkinson's, develop dementia, it's not just alpha-synuclein. They have that same amyloid protein in their brains as an Alzheimer's patient. And the severity of their brains, with the same scans, the severity of their dementia relates more to how much amyloid they've got, not how much alpha-synuclein. Of course, we can't image yet alpha-synuclein. So again, If these normal is blue, normal aging, and Alzheimer's that red, but here's a Parkinson's patient with dementia, and it's kind of right in the middle. Uh, and so what we're seeing is some of the same studies that have been done in Alzheimer's disease being done in Parkinson's. Again, right now, very small numbers of patients and not treating the whole brain yet for safety reasons. Uh, there have been attempts, remember, the most important protein that's abnormal in Parkinson's disease is the protein, normal protein called alpha-synuclein. It's there in an abnormal form. And just like there were studies of the antibodies against amyloid in Alzheimer's disease, there have been studies of antibodies against alpha-synuclein in Parkinson's disease. They failed. And the question is, did they fail because they couldn't get enough antibody in? Because when you do this in animals and you add focused ultrasound to the mix and get literally in the animals and you measure it, get at least 5 times as much antibody in, now you get clearance. It hasn't yet been attempted in humans. And partly because we don't have the imaging yet in humans to monitor it. So there's anti-amyloid scans that are FDA approved. There are no yet anti-synuclein scans available. So what about things you want to get in would be beneficial to a patient with Parkinson's? Well, a scientist named Ellen Sadransky at the NIH, close to 15 years ago, noticed the connection between Gaucher's disease, and Gaucher's disease is the commonest inherited neurological disease in Ashkenazic Jews, and Parkinson's disease. And that in particular, there were people who were blood relatives of people with Gaucher's who had a much higher incidence of Parkinson's than you'd expect. So if you carry one of these genes, you've got a six-fold and greater chance of developing Parkinson's than you would just by age. And then when they started to look at everybody with Parkinson's, when they got autopsied or spinal fluid, they seem to have low levels of the same enzyme that's absent in Gaucher's. So in absent Gaucher's is what's called an autosomal recessive disease. You don't have any good copies. Both copies you inherited from your mother and from your father are both abnormal. You don't have any of the good enzyme. And again, you get a serious disease. Uh, but even if the single copy, you have an increased risk of Parkinson's disease. And again, all Parkinson's patients have low levels in their brain. There's already a treatment. There's enzyme replacement therapy for many conditions, usually in childhood. Most of them are inherited, where you don't have enough of the normal enzyme. It's manufactured, FDA approved. It's for Gaucher's. It's been available for 20 years, and it works really well for the problems in Gaucher that affect the liver and the spleen, but it doesn't work for brain aspects of Gaucher's because the enzyme is too big to get into brain. And so the question is, can you open up the blood-brain barrier and get it in? And there's already been a small study in Canada that shows that that's true. So again, 4 patients. So Neil Litzman, who's a neurosurgeon who's been working on this for 20 years, these patients had Parkinson's disease. They had a known mutation of this enzyme, and they were able to get the enzyme in. It seemed to be safe, and it's only 4 people. It looked like their Parkinson's was somewhat better. And my major disappointment is this was published in 2022, and I don't see any further results since that time. I'm getting a little impatient in the latter stages of my career. I'd like to actually, see some results, well, let's just say before I retire or die, things want to move a little. It used to be very proud of, and now I'm kind of a little frustrated when I go and search the medical literature for things and I find the most recent stuff I did. So somebody's got to pick up the torch here. So here's the status report. Uh, and so there are now for focused ultrasound uh, three separate FDA indications for Parkinson's. There's a fourth one for essential tremor. Oh, that's it. Okay, where I don't know where the red thing came from before. Okay, but again, tremor. Remember, we don't do the tremor on both sides because we're still concerned that we might have problems with speech and swallowing. Pallidotomy, one side, and this newest thing, the PTT on both sides. And again, outside the United States, somebody wants to go to Madrid or Barcelona, they're lovely places. Those are the only groups that really I would trust to do that and they can do both unilateral and bilateral STN lesions. And again, the research right now, opening up the blood-brain barrier to clear out amyloid and opening up the blood-brain barrier to deliver the beneficial enzyme glucose cerebrosidase. Uh, that's what's moving ahead. The thing that is not moving so quickly is getting some of these things approved by Medicare. They're in the middle of a big reorganization. So it's a good time to call your congressman and say, what the hell is going on here? Because this long gap, they're both branches of the federal government, the FDA and Medicare, but they actually don't seem to talk to each other. Then that's what the biggest issue is, getting Medicare coverage for our patients for anything other than tremor. And tremor's been FDA approved since 2018. And with that, I will be happy to take whatever questions you have.
Okay. Wow, thank you. One question is, when you're having the focused ultrasound, what does it actually feel like?
Well, in certain circumstances, the thing that bothers you most is this frame screwed to your head. Sometimes with the low-level sonications, you may feel nothing. The technician will say, sonicating now. And it'll go on for 15 seconds. You won't feel a thing. At other times, particularly at the end of the pressure, you'll feel heat, you'll feel pressure, and sometimes that pressure is intense. One patient did say to me, it felt like his head was going to explode.
Oh,
So somewhere between those, but you have an IV, they can't knock you out, but they certainly give you pain medications. They can give you things for anxiety. They give you things for nausea. Nausea is really common in the machine. Apparently, it tickles your middle ear and it gives you a sense of whirling or vertigo. So that's everybody gets something for nausea. So again, and actually you can almost predict how easy it's going to be. Before you have focused ultrasound, they send you for a special CT scan. They don't care about your brain in this situation. They care about your skull. And they look at the qualities of your skull and they give you a number, your skull density ratio. And that tells you how much energy is going to get trapped in your skull.
mm,
Uh, and if it's below a certain number, the FDA doesn't want you doing anything that's below zero point 0.4. We've done people down to around 0.3. But if you're in those borderline regions, it means your skull is going to absorb a lot of that energy and you're going to feel the heat and pressure. You got somebody, grade 1, 0.6, 0.7 on a 0 to 1 scale, you're probably not going to feel a thing.
fascinating. Okay, here's a question. Dr. Fishman, is ultrasound treatment alone used to assist elderly Parkinson's disease patients who currently experience minimal tremor and is currently not diagnosed with Alzheimer's disease? And is there a best, in quotes, is there a best treatment besides medication, exercise, and verbal stimulation?
Well, no. So age is actually not a limitation in focused ultrasound. Somebody just published a paper looking at patients above and below age 80. And the group above age 80 did as well as the group below age 80. The average age of people is in their 70s who do this. But The question is, what do you want to improve? And all of these surgical therapies uh, only improve very specific symptoms. Nobody with mild tremor should have any surgical procedure. To be worthwhile, the risk of having your brain coagulated, it has to be functionally interfering or at least very bothersome in spite of medication, or you just can't tolerate the medications. Uh, for the other aspects of wearing off, uh, the best you can be is almost as good as when your medications are working. The things that none of these things help balance. So if you have problems with balance, and again, for people with elderly with it's a double whammy. Everybody's balance declines with age, and that's probably for vascular causes. If you have Parkinson's and now you're in your 80s, balance is one of the major issues with falls. That's not going to be improved by any surgical procedure, and frankly, they make them worse. In terms of dementia, that's a work in progress. There is no, uh, there will be research studies, but it's not a clinical therapeutic. I would love to see what's nobody's done yet. Nobody's taken the anti-amyloid antibodies, and there's a trial ongoing and tested them in people with Parkinson's dementia. If they've got amyloid in their head too, maybe they'll get better.
Okay. At what stage of the disease is focused ultrasound considered for a PD patient?
Okay. Again, depends on symptoms. Uh, Tremor. Tremor isn't stage specific. There are some people who have early stage Parkinson's. Are called tremor predominant Parkinson's. And because tremor doesn't follow stages, tremor does its own thing. If you have a bad tremor, whether or not you've had Parkinson's for a year or 20 years, and the medications aren't cutting it, or the medication side effects aren't working, again, just like for DBS, that's an indication of focused ultrasound. And then, like DBS, the other big group are these middle stage Parkinson's patients, where, say we're in the 5 to 10 year into Parkinson's, where the medications still work, but they work erratically. You know, the joke around Passover is, for evaluating patients, we have our own 4 questions. And the 4 questions for any of these therapies are uh, how much of your waking day you're on medication? What fraction of your waking day would you consider yourself off? And usually, if the patient answers at least 25%, they ought to be considering it. And then you ask the next question, well, when you consider yourself off and your medications aren't working, can you still do most things you want to do? Can you only do some of the things you want to do? Can you only do a few of the things you want to do or need to do? So if you're down to some of the things, that's poor quality off. Then you ask this next same 2 questions for dyskinesias. Uh, what fraction of your waking day do you have levodopa induced dyskinesias? And how much do they interfere with your ability to, go about your daily business? And so those 4 questions for both DBS and FUS, they determine if somebody has that fluctuation that would justify either procedure. And that's usually these moderate stage things. As I said, my biggest disappointment is the lack of research, the lack of things to help the more advanced patients. It's like the research community says, by the time we get going, you're going to be too far advanced. I think that's a horrible message to send
Mm,
patients.
yeah. What are the best outcomes for this procedure?
Well, the best outcome with tremor is easy to measure. Elimination of tremor. So if average is a 70% reduction, you're going to have some failures, zero, but you're also going to have a fair number of people who are 90% to 100% better. So that's the best outcome for tremor. The best outcome for dose fluctuation is being almost as good when your medications are worn off as you are with them. Some of the patients are able to cut their medication by 30%, 40%, 50%. It's rare to see somebody totally go off medication, but reduction of medication in the 30 to 50% range is not uncommon.
Um, who and when should someone be referred for focused ultrasound versus the pump versus DBS?
Okay. Well, I'm glad you mentioned the pump because the pump is a growing alternative. And usually, uh, I'm not a big fan of centers who I describe as one-trick pony. If you go to a center, you should have that discussion of all of them at the same time. And then, because the issue is, uh, if a center does all of them on a regular basis, they can kind of give you the pros and cons, just like I tried to do with that slide in general, about which one is best for you. Uh, for the people with cognitive impairment, great. Pump doesn't do anything to the brain. That's wonderful. Uh, for that, for dose fluctuate those. So the pumps are mostly for dose fluctuations. As I mentioned, uh, age is a big determiner of FUS versus DBS because uh, as we get older, we are not great surgical candidates. The likelihood of a complication and the likelihood, so even if a person at 30 has a bleed in their head that's a half an inch across, and a person at 70 has a bleed in their head that's a half an inch across, who do you think is going to recover faster and who may have more complications? So surgery in almost every studies, age is a big. And the other part is the adjustability of DBS. Younger people are saying, hey, you got pretty good 5-year data. But what about your 10 and 15 and 20-year data? If you're asking about that, you should have DBS, not FUS. If you're thinking beyond the 5-year range, and for focused ultrasound, you do start to see the tremor coming back. If you're looking beyond that 5-year range, you ought to have DBS, not focused ultrasound.
Why does the tremor come back?
Well, it probably comes back for 2 reasons. One, uh, the disease gets worse. You've made a lesion at one point in time, and on the basis of what the tremor looked like then. So the tremor comes back for 2 reasons. One, while you're doing the procedure, you can't tell injured brain from dead brain. If it's stunned, the tremor may go away. And that's why on all these studies, it's not what happens at the end of the procedure. When we look at data and I say, oh, it was 70% data, we're looking at 3 months. Because if the brain is injured and not killed, well, that's the whole reason the side effects get better in the next few weeks or months. But there's a risk that the tremor will come back. And that's why, again, things may look great. Maybe that number would be 90% on the table, but what counts is at 3 months. But then the question is the disease getting worse? The whole reason that people come back for reprogramming with DBS is that Parkinson's and other tremor conditions are not one-shot deals. They're progressively worsening. And then that's the advantage of DBS. If the tremor comes back and gets worse, you can adjust the settings. Give you an example, a really good DBS implantation, we turn it on the OR, and if at a setting of 1, you get tremor goes away, then we're not done. Then I keep cranking up the current and I ask the patient to talk. And again, my usual flippant thing that I usually use. So when I'm testing speech in DBS, the phrase I give patients to repeat is, I want to get out of here as soon as possible, which they all agree with. They get very motivated, and I'm checking their speech, and I keep cranking that thing up to 2, then I crank it up to 3, and then I'll crank it up to 4. And if they're not feeling anything funny, and they have good, clear speech at 4, then I know that that's going to be a really good implantation for many years. Because what it's telling me is I can get rid of the tremor at a setting of 1, but I can crank it up fourfold before this person has any side effects. So what that means is if a year goes by and this patient has a really bad tremor, I can turn that device up to 2 or maybe even 3 and regain that tremor control. That's not something you're able to do with focused ultrasound. And right now, the whole field is wrestling with the whole question of redos. So if you remember, we got patients now, we did the experimental studies. There are patients who were more than 10 years out of focused ultrasound that we did back in 2013 and 14. And now we're starting to do redos. But that's a work in progress. And can we reestablish, if the tremors now come back 10 years later, can we knock it out again? I wish I could say more, but it's only been a handful of patients. And what's annoying is there's no published study about redos yet in the literature.
Okay. How do I get my meds, carbidopa, levodopa, to last longer than 3 hours, especially if it takes 45 minutes to an hour to kick in? And are there any new meds in the pipeline to stem the progression of this disease?
Okay. The first part is there are two, so there are lots of so-called controlled release forms of carbidopa levodopa. And I will steal a somewhat crude line from the head of the movement disorder program at Columbia. Uh, Her comment is CR doesn't stand for controlled release, it stands for crappy release. And these things just dissolve a little. So the first thing that was truly different, which is now going generic, is Rytari. So Rytari has been around for years now. Rytari uh, should have less of that. It is designed, remember, Rytari is not a tablet. Rytari is a capsule full of little micropills. And some of that are designed to dissolve slowly, to kick in quickly, and others are designed to last longer. And now, the cynics among us would say, now that Rytari has just gone generic, the same company that made Rytari about a year or so ago introduced another one that's even better called Crexont. Crexont looks to be a little better than Rytari. Rytari is astronomically better than Cinemet CR. So again, for things that last longer, either Rytari or Crexont. The whole reason for that are the pumps. The pumps are designed to bypass the gut and give you uh, the same chemical, levodopa, and again the pumps, Vialev, which is it's almost the same as Cinemet. It's a modifier to be more soluble, and again for dose fluctuations, that's the thing that bypasses the gut and the poor absorption. So the things that are out there, and again, just relatively new. Crexont, I think, has been out for a year or two. Vialev's been out for a year. Those are things for dose fluctuations to have your medications last longer and kick in more consistently and quicker.
Um, I think you've talked about this, but what are the possible side effects or negative aspects of this procedure?
Okay, when the heat spreads to a nearby area, the two commonest side effects are numbness on the face or on the treated hand, and the most serious side effect is balance. Sometimes there can be slurring of speech, and sometimes some degree of weakness of the hand. And those are the most serious side effects from the procedure.
And that's permanent if that happens?
And it doesn't have to be, but it can be. I would say severe and long lasting about 1% of the time.
Okay. So this is again kind of the same thing. What are the risks of having this done? And if it doesn't work, can it make your symptoms worse?
It usually doesn't make you get other symptoms. It doesn't make the ones you have worse. Again, except for the fact that balance. Remember, balance and speech are two things that are really problematic for many Parkinson's patients. So you really don't want to see speech worsen, and you really don't want to see balance worsen. What is the biggest threat to somebody with advanced Parkinson's? It's falls. And and I'm really discourage people with marginal balance for getting involved in this. Even a little bit of, if you're walking with a cane and your balance gets any worse, you're going to need a walker. If you're walking with a walker and you're still falling, you're in bad shape. You should not get involved in these procedures.
Um, is focused ultrasound now being applied to scan part of the brain, and are the results any better?
Well, uh, the thing that's being used, I don't know if you what that person means really by scanning the brain. Ultrasound's been used to develop images for a long time, but one of the things that's been done is low levels of energy are being used to kind of train the brain. And and this is very similar to what's called transcranial magnetic stimulation, transcranial electrical stimulation. Uh, you kind of try to essentially activate the brain. It's being used for everything to suppress addiction, to and cravings, to try to enhance movement by having a training paradigm. There's been a study at the Cleveland Clinic where DBS was used to try to improve recovery after stroke by stimulating it. And so, again, with lower energies, it's in that same family, not as well developed. I think in Hopkins, they're doing a lot of experimental studies with transcranial electrical stimulation, where they stimulate, they put the electrodes on your head, and some of that current is going to go into brain. And in particular, you can do that even with a magnetic coil. So again, it can train the brain.
And I think this is the last question. If anybody has another question that we haven't touched on, feel free to write it in the chat. But here, what centers would you recommend for this procedure?
Uh, well, that's kind of a loaded question in some ways. So the answer is for focused ultrasound, uh, the center that has the largest experience, both in developing this in patients, is where I am at the University of Maryland Medical Center. Hopkins now has one. I think uh, Franklin Square, I know Justin is trying to get, my colleague Justin Martello is trying to get one in one of the local ones. He's got one in Christiana. Then Zach Levine, who does tons of DBS, has one of the devices in the Washington area. So when we started this, there were four of these devices in the Western Hemisphere, and now there are 60. So people have lots of options. We are the oldest, most established, and have done some of the largest numbers in the country.
I think that's it for questions. Does anybody have, oh, wait, here's one. Let's see here. Oh, outstanding talk from a leader in the field. Thank you. Certainly combining focused ultrasound and monoclonal antibodies is a priority for treating cognitive deficits in PD. Are there efforts to combine focused ultrasound and, oh my God, I can't pronounce this, CHOLNIERGIC treatments given that deficit in PD and the limited dose range for those drugs? Um,
Okay.
yeah, basically that's the
Okay. Well,
question.
like I said, uh, I don't think there'd be much of a role to that. The cholinesterase inhibitors, we're talking about things like Aricept and Nipazole, they certainly are FDA approved in Parkinson's and they do improve symptoms. They're relatively small molecules. Uh, their dose range would probably not be improved by opening the blood-brain barrier, because the issue is their side effects would be within brain. Remember, these, oh, they are in the same family as the nerve gases. So nerve gases, if you want to have a really highly potent cholinesterase inhibitor, the nerve gas VX is the champ. And actually, the cholinesterase inhibitors uh, are useful in nerve gas poisoning because they compete with it. So a moderately active cholinesterase inhibitor, if it displaces a really bad one, will keep you from seizing to death. But again, it's really the bigger molecules, like the antibodies, that the future of blood-brain barrier opening is targeted on. And I agree with the questioner. I I am starkly disappointed that there's not more research, even on the monoclonal antibodies in Parkinson's dementia at all. There's one research study I could find when I look, has been published yet that's recruiting.
Can you please spell the name of the drugs that are used to extend carbidopa?
Okay. Uh, it gets okay. Remember their brand names. So the one that's the newest is Crexont, Crexont. The other one that's been around for a long time is Ritari, Ritary. They're made by the same company. Uh, you will see Crexont advertised on television, even on streaming services. So unless all your streaming services have no commercials, you will see commercials for Crexont. The other one that is the pump infused under the skin is Vyalev, Vyalev. These things always drive me crazy because I can never remember where a Y is and where's an I, in that.
Okay, any other questions from anybody? Nothing in the chat. All right. So this has been recorded, and thank goodness, and will be up on the website. What do you think, Michael? By Friday? So if you just go to the MAPS website and then click on events and scroll down to conversations with a doc, you'll see actually they've all been recorded over the years. And Dr. Fishman, thank you so, so much. Oh, another thing for those of you who are in the area, Dr. Fishman will be the keynote speaker at the MAPS Symposium on November the 15th. So you can hear more of what he and other experts have to say about all of this. And I think that's it. Thank you very much.
Yeah, well, thank you guys for your attention, and thanks for organizing this and all the support in it. And always happy to support a
Oh, wait,
great
one
or
more question. One
oh,
more question. I'm sorry. Oh, no, it just says thank you. Okay.
okay. Okay. Okay.
So thanks,
Okay.
everybody, and have a good evening. Thanks, Dr. Fishman. Thank you.
Thank you.
Good night.